On today's show, I've got Sue Falsone. Sue is the owner of Structure and Function Education and is an associate professor of athletic training at A.T. Still University. She has an extensive background working in both professional sport and also as an educator, and she is the author of one of my favourite professional books called Bridging the Gap from Rehab to Performance. So it's a great pleasure of mine to speak to Sue today. If you're enjoying the episodes and you'd like to receive them as soon as they come out, then please subscribe. And don't forget to check us out on Instagram under Inform Performance. It is an absolute pleasure for me to welcome Sue Falsone to this episode. Sue, thank you for humouring the idea of having a chat with me. It's a rare privilege that you get to enjoy reading a book and then have a real conversation with the actual author themselves. So thank you for coming on.
Oh, gosh, thank you so much for having me on, and thanks for those kind words. I really, really appreciate that.
Just to set the scene for the listeners, would you be able to just tell them your background and what you do?
Yeah, for sure. I'm a physical therapist, athletic trainer, and strength coach, and have functioned in all of those roles in one way or another. I went to physical therapy school at Damon College in Buffalo, New York, very, very long time ago. And then I did my graduate work at UNC Chapel Hill in sports medicine and human movement. And then worked for about 13 years for Athletes Performance, which is known as Exos, and worked for the LA Dodgers for about 6 years. And then went on from there, was the head of athletic training and sport performance for the U.S. men's national team for soccer or for football. And then currently am a associate professor at A.T. Still University in the doctoral program. And also currently own an education company called Structure and Function Education.
That's a hell of a CV you've got. And are you still working with any professional teams at all?
I do some team consulting, but I definitely still treat patients. I've got a concierge practice where I still have professional athletes and either travel with them or go to their homes and kind of treat them as individuals. So I haven't worked with let's see, I guess it's been since January since I've done any consulting with any of the teams, but yeah, definitely still consult and work with patients on a weekly basis.
That's very good. Are you mostly working with baseball and soccer when it's athletes, or do you work with different athletes?
Yeah, I definitely, right now my two clients are Major League Baseball and the NFL.
Oh, cool. So you get a good mixture.
Yeah, a little bit of a mixture for sure.
And we're gonna dive straight into it. I heard a female physical therapy student recently say to me that she couldn't work in sport because she's a girl. My first response was, you have to look up Sue Falsone. But I'm interested to hear your views on this statement, or perhaps if it is a wider issue. Were there any barriers for you when you initially started working in sport?
There were barriers, but honestly, I didn't think about them. And it breaks my heart when I hear young women say that, when they say things like that, like, oh, I can't, work in professional sport because I'm a girl. Because there's so many teams and so many organizations that absolutely will give you the opportunity. They just want the best person. And I think like with the athletes, they certainly don't care. They just want somebody who can help them perform better and to feel better. And so, I would say, yeah, there were definitely some barriers, but, I tried to just focus on the opportunities that I was being given and being ready to execute upon those opportunities. And so, I never really kind of focused on those barriers. I'm sure they certainly were there, and I think they still are there. But there's plenty of organizations that'll give you an opportunity. And
how would you advise a girl who, like the one I've mentioned, who, and I'm sure she's not alone, how would you advise them on sort of, I guess, starting their career in sport and getting their foot in the door somewhere?
Yeah, I think that, internships are a great way to get an organization to have the opportunity to see who you are, what you're about, the kind of work you do, how you hold yourself as a professional. And then, internships are really just 2, 3, or 4 month long interviews, really, right? So it's just a great way for whether you're male or female to get an organization, if you want to get into professional sport, to get them to know you. And so there's a lot of great formal internship programs that I know we have in our different leagues, and I'm sure it's the same pretty much everywhere. That if you can apply and get one of those internships, that's usually a really, really great way to go. The other thing I always tell people is to get themselves to conferences where people are speaking in the league that they want to work at. So like for baseball, there's a conference every year that most of the baseball athletic trainers will go to, to make sure you get to that conference and you meet as many people as possible. Or, same thing for American football or whatever, same thing for soccer. So I always tell people, like, get to those conferences where the people who are working in the league are that you want to be in, and make it not about the name. Like, the more people can get to know who you are as a human and who you are as a professional, when that opportunity comes up, they'll be like, oh yeah, remember we met that person, and here's his or her resume. But the more personal you can make it, the better, because these people are getting inundated with resumes and people who want opportunities all the time. So if there's something you can do that makes you stand out as a human and as a professional, that's usually my advice to people.
And I guess from what it sounds like that applies to both genders. It's just your own personal approach, and you get these opportunities on personal merit.
Yeah, I think so. Because I think, I know there's plenty of organizations who are apprehensive to hire a woman for whatever reason. And I'm sure that there's opportunities and things that I didn't get because I was a woman. And I just choose to not reflect on those. I don't choose to give those things the energy, and choose to focus more on the opportunities that I was allotted and was given, and made sure I was prepared for those. Because there are plenty of organizations that really just don't care what your gender are. They want the best person for the job. And so to try to focus on those positives and not to get too discouraged if for some reason you get the feeling, or, you don't get something and you think it's because of your gender. Yeah, I'm not saying kind of let things happen that shouldn't happen, right? But I tend to just focus on those opportunities that I have. And there's plenty of organizations that will give you that opportunity.
Yeah, so people should still go for it.
Yeah, go for it. Absolutely. Absolutely. I mean, you're going to get rejections no matter what gender you are. I mean, working in professional sport is really difficult. There's not that many teams, depending on what league you're in. There's under 30 teams. So really, there's only 60 jobs in the entire, in the US at least. Maybe there's only 60 jobs in the entire league. So it's like, forget about even just your gender. Like, those are just difficult jobs to get, because a lot of times when people get those jobs, they don't leave them very often. So, I think those jobs are difficult to get for both men and women, just because there's not a lot of them. And so, to really just focus on the things that you can control, and being a great professional, being really good at what you do, having wonderful interpersonal skills, caring about the patient, which is what it's all about, and just really focusing on those things. The right opportunity is going to come along, no matter what gender you are.
That's really promising advice. So yeah, thank you for that insight.
Sure.
I want to talk about your book, Bridging the Gap from Rehab to Performance. I really enjoyed reading it. I think you're able to convey really highly educational and informative information, and sort of convey it in this conversational and never dumbed down way. It was kind of like reading a textbook, but in a way that you can read it for leisure.
Oh, good. Thank you.
I think one of the things you do a really good job of is you discuss, I think, the kind of full toolkit of approaches and methods that coaches or therapists use to treat either injuries or perhaps enhance performance. But you managed to do this inclusive of discussing research or the current state of the research for that tool. What I'm interested to know is, how do you think therapists or coaches can strike a balance between being open-minded to what they use or what philosophies they apply, but still being critical from a scientific standpoint?
Yeah, it's definitely a balance, right? And I think that people love to talk about this concept of evidence-based medicine. And for some reason, evidence-based medicine became equated with research. And really, when you look at the foundational definition of evidence-based medicine, it's the best available research, which in some areas that means we don't have much research at all. So it's the best available research, clinician experience, and patient values. And those three things are combined to create what's called evidence-based practice. And I don't know where along the line that sort of best available research portion of the concept of evidence-based medicine became larger than the other two. And I would love when people want to have the argument on Twitter in 140 characters. People will say, well, you're valuing clinician experience more so than the literature. And I would argue that no, not at all. I think those three things are very equal when it comes to the practice of evidence-based medicine. Patient values and clinician experience are just as important as the best available research. And in some areas, I work with really high level individuals. There are not any randomized controlled trials on 7 foot tall NBA players. So the only thing I can look to, the best available evidence in that population might be a case study or a case series. So for me to feel like I always have to find a systematic review, a meta-analysis, or some type of randomized controlled trials, depending on what I'm doing or who I'm working with, those are not super applicable to the patient population that I'm working with. So I think we have to kind of revisit the foundational definition of evidence-based medicine, best available research, and how we can best, how we best utilize that, patient values and what the patient believes is going to be a valuable treatment for them, and clinician experience, and just recognize that all those three things is what makes up evidence-based medicine.
I guess the science quite often is playing catch up with how we treat patients based on experience and judgment, or I guess occasionally intuition as well.
Yeah, 100%. I mean, at the end of the day, research or practice drives research, and then research informs our practice. But that first part of, the way we even have a research study is because people are doing it in the clinic, or people are seeing some type of phenomenon and they say, hey, we want to study this. And so then they go to study it, and then they go to look at it, and then they take what they found and then they, turn it back around and inform our practice. So I think that we have to recognize that clinical experience drives what's happening in the research, and that the research then informs our practice. And so it's this big circle. But, our clinician experience and what we're seeing every day to day, every single day as we're working with patients is super valuable.
And in your book, you managed to include a real wealth of different tools or philosophies for how you treat and enhance the athletic body. When you come across, say, a new tool or a new idea that you haven't used before yourself, how do you go about deciding whether you're going to implement it or not?
Yeah, that's a really great question, because there's so much stuff out there now that it's almost overwhelming. I mean, especially with technology and different things that are coming out, it can get really overwhelming, not only for a new clinician, but even for an older clinician who's been practicing for a really long period of time. And they're trying to kind of keep up with some of the new things that are coming out, or that their patients, right? Patients are so informed now because of the internet that patients are coming in and saying, hey, I read about this on the internet. And if, you haven't heard of it, you're like, oh gosh, like, I need to go look that up. So there's so many things that are just coming down our pipeline. And so you've got to be really critical when it comes to any type of a tool. And for me, I think sometimes people confuse their philosophy with the tool that they're using. So like for me, my philosophy is unwavering when it comes to my clients and my patients. My philosophy is to restore and maintain the homeostatic balance of my patient. So whether that's biochemically, biomechanically, biopsychosocially, bioneurally, whatever that means, like it doesn't matter. And then the tool I use to express that philosophy is just whatever happens to be in my hand. So is that a needle? Is that my actual thumb? Is it a foam roller? Is it some type of kettlebell or a weight or whatever? Like the tool expresses my philosophy. And I think what happens sometimes is that people confuse their tools with their philosophy, or even they confuse their continuing education path with their philosophy. Now, some continuing education is a philosophy, but what I wanted to do in the book was just to kind of make the point that everything fits, right? Like whatever tool or whatever kind of school of thought you want to follow, it all fits within this model. And it's just sort of a matter of where do you want to put it and where do you want to put your stock into that tool. But yeah, I'm pretty critical when it comes to new tools and flashy toys. I mean, I've got a concierge practice, which means I'm on the road. I don't have a facility. So if it doesn't fit into my little backpack, it doesn't go with me. And so I'm pretty, for something to come out of my tool bag, what is going to replace it needs to be really, really good. So I'm pretty critical.
No, thank you.
Yeah.
Early on in your book, you share your framework called the slide for how you work on the sort of continuum of an athlete being injured through to them performing at the highest level in their sport. If it's not stealing too much from your book, can you share or describe this framework for the listeners and give a sneak peek to your model?
Yeah, of course, of course. It's for me, I call it a model or an organizational system, because for me it's really not a continuum. Like, a continuum implies you have to pass one part of it in order to move on to the next. And so what I really wanted to do was to present this sort of model where we, as functional interventionists, can say, okay, each part of this model is important. I might work on one part of this model on any given day. And we know darn well that there's people playing sport who maybe have not mastered one section of this model. And that's okay, right? Because their athletes are great compensators. And so how do we sort of create this organizational system that says everything is important, but we do it in an organized fashion, right? Because to say everything's important is intangible. So for me, it's kind of breaks down into 7 boxes. And so that first box is really about identifying the pain generator. So making sure that we know what tissue is the issue. And there is some evidence that says, okay, the tissue that is the issue doesn't matter. But I would argue that it does matter, right? Like, I think that if I've worked with a patient who has been misdiagnosed, or we don't have the proper diagnosis, it makes our treatment interventions way more difficult. So I think a proper and accurate diagnosis is really, really important up front. And that's where the pain generator comes into play. And that is, I kind of equate that to the source of people's pain. And then the motion segment is, how do we frame that person's pain within the kinetic chain? And so the motion segment is really more about, okay, that's the cause of someone's pain. So pain generator and motion segment go hand in hand the way, and can be equated to cause versus source. So the source of someone's pain and what's the cause of someone's pain. And we're always evaluating and treating both of those things, in my opinion, in my model. And then as we kind of move down, we look at things like psychomotor control. So psychomotor control is really about the brain being able to connect to the body. And so if we've ever had a surgery, or you've worked with someone who's post-op, like sometimes they're looking down at their leg and they're physically just trying as hard as they can to contract their quad. And it's a very mental engagement within what's supposed to be firing. And there's a time and a place for that. But obviously we know those people have to be able to integrate that muscle contraction, or that specific sort of isolated movement into a more integrated complex motor pattern, where they're not necessarily thinking about individual muscles firing. They're just thinking about executing the motor program. But for a period of time, psychomotor control is a really important thing to work on, depending on what's going on. And for me, that's really about letting prime movers be prime movers and letting stabilizers be stabilizers. When a stabilizer has to become a prime mover and a prime mover has to become a stabilizer, the body gets really angry. So if we kind of think about like TFL and glute med, if glute med is really the muscle where power is going to be developed, and glute max really for extension and external rotation at the hip, and the TFL has to be, and the QL have to be able to stabilize the lumbopelvic hip complex in order for the glute muscles to produce power. Well, sometimes the TFL becomes the prime mover, and then so that the stabilizer is now becoming a prime mover, and then we get IT band irritation, we get lateral knee pain, we get greater trochanteric bursitis, we get whatever diagnosis you want to call it, because the stabilizer has become the prime mover. And so there's a time and a place for making sure everything is sort of doing its job. Then as we kind of continue to move down the organizational system, we look at somatosensory. And somatosensory for me is a really interesting part of the model, because that's really where all of our nervous system stuff comes into play. How do we manipulate the visual system? How do we manipulate the vestibular system? How do we manipulate balance and proprioception and all of those things, and motor learning, and how do people best, um, have skill acquisition and motor control and different surfaces and sort of all of those things. That's really where um, all of that kind of fun stuff lies within the somatosensory box. And then as we continue to move down, we have fundamental performance. And for me, that's about strength and power training. People need to be strong, and they need to be able to express that strength in a short period of time, which, is known as power. And so how powerful can people be? And strength is a fundamental component of power. So for me, that's where we pick up heavy stuff, we put it back down, we do it again, and we try to do it with speed. And so we just develop fundamental strength and power in that box. And then how do people express power in fundamental athletic movement? And that's really where fundamental advancement comes into play. So that's where, okay, how do we take that power and that strength and express it in linear movement or multidirectional movement or jumping and landing? And then how do we teach people to go from any one of those movements to any other thing? So that's just really foundational athletic movement in that box. And then as we continue to move down into this final box of advanced performance, that's when it matters. Is someone a football player, or are they a baseball player? Is someone a marathon runner? What type of sport are they playing? And so that's when things get really sport specific. And, people will ask me a lot of times, how do you league hop, right? Like, you've worked in Major League Baseball, you've worked in the NFL, you've worked in the NBA, you've worked in international soccer. Like, how do you league hop? And it's really because none of those things change until that very, very last box of advanced performance, where it's all about terminology and technical aspects of the sport. Everything else I talked about before that doesn't change, right? Every athlete needs linear movement. Every athlete needs multidirectional movement. Every athlete needs power. Every athlete needs everything else that I talked about. It's just that last piece where it gets very, very client specific at the end. And so really, we kind of take this entire organizational system and kind of take the intangible of table to field and make things really, really tangible into really specific boxes.
So it's a much more flexible lens for how you work with somebody, rather than, a pyramid where A tells you to then go on to B, which tells you to go on to C. It's a lot more open-ended.
It is. It's definitely more open-ended. And I think it helps too, to from an interprofessional relationship standpoint too. Like, there's plenty of people who I work with where, man, it's all about weight room stuff and creating strength and creating power. But maybe they don't understand some of the vestibular or balance stuff as well. And that's okay. They don't need to, right? Or maybe they don't have diagnosis in their skill set, and that's okay. We all don't need to be experts at it all. We just need to have friends who are experts at it all. So if someone feels really, really comfortable in the weight room, but they don't feel super comfortable diagnosing someone that has shoulder pain, no problem. You don't have to know how to do that. You just have to know who to refer in order to do that. So I think it also kind of presents a way for us to work interprofessionally together and to kind of say, okay, here's where my strengths are. Here's where maybe not my strengths are. And that I either need to go get further education, or I need to make a friend in this area.
And it's athlete-centered.
Yes, yeah, which is absolutely huge, right? At the end of the day, that's what it's about, is an athlete-centered model.
And while I've got your attention, what I want to talk about is dry needling. It's obviously not a new tool, but I'm aware it's something that you're an educator for. In the UK, where I'm from, dry needling within physiotherapy practice is within the scope of practice, providing you've done a credible course. Now I'm in America, obviously state by state, each state has a different scope of practice for whether it's included or not. For the clinicians who are out there who, whether it's geographically they haven't had exposure to it or they just haven't used it before, could you sum up what it is and perhaps justify why it could or should be used in practice?
Yeah, the needling. I do tend to call things needling now, because there's it's a bit of a controversy depending on what state you're in and whatnot here in the U.S. It's funny, I have done a lot of my training in the UK, actually. And so I am a member of the AACP and have taken those accredited courses, which is great. And here in the United States, it's a little bit different. And so really dry needling in the United States is kind of looked at differently than acupuncture. But the way I kind of look at it is acupuncture, traditional acupuncture is sort of this broad term, right? It's like saying you're a physician. If someone tells you you're a physician, or they say, "Hey, I'm a physician," your immediate question is, "What type of a physician are you? Are you an orthopedic surgeon? Are you an internal medicine doctor? Are you an OBGYN?" Right? Like, there's all these things that sort of fall under the topic of being a physician. And kind of same thing, like traditional acupuncture is this really, really broad term, and there's different things under traditional acupuncture. There's traditional Chinese medicine. There's auricular acupuncture. There's peripheral neuromodulation. There's dry needling. So dry needling is like this one very specific thing under Western medical acupuncture. And it's one really, really tiny aspect of traditional acupuncture as a whole. And so dry needling is really, really rooted in Western medicine. Even though we use the same tool, we use a fine filiform needle and we insert that into the body in order to create a healing response. And that healing response is really strong because we can create a healing response locally, segmentally, and systemically. So a lot of different things happen when we insert this fine filiform needle into somebody's body. And so dry needling, like I said, is really, really rooted in Western medicine. There's no discussion of anything from an Eastern medicine standpoint, chi or meridians or those sorts of things. Those things are rooted more in Eastern medicine. But in Western medicine, as a physical therapist, who's gone to school for anywhere from 4 to 7 years, depending on when you got licensed, we have that knowledge in anatomy and physiology and pathoanatomy, pathophysiology, safety, all of those sorts of things. And then we take a class to sort of learn how to utilize or add this tool to our toolbox. And it can be a super powerful tool. If I'm in a situation where I can use it, I often will go to that tool because of the incredible local, segmental, and systemic things that can happen when we utilize that tool. But with great power comes great responsibility, right? So the first time we're being invasive in the body as a clinician. So we have to understand and respect that there are a lot of systemic things that can potentially go wrong if you're unfamiliar with your anatomy, if you're inserting a needle at a wrong angle, at a wrong depth, or if someone has a systemic reaction that you don't know how to deal with. All of those things come along with that skill of inserting a needle into somebody. So, it's a super powerful tool, but it's definitely one that you want to have great education in, great understanding in, and really have a respect for what the technique is.
So obviously the science or the kind of clinical reasoning behind why you'd use it is universal, regardless of which state you live in. Is it more of a legislation issue as to why you can do it in one state but not another?
It is, for sure. So yeah, I mean, the body doesn't know what letters you have after your name, right? So it has no idea who is inserting the needle into the body. The physiology is the same despite the letters after your name. But yeah, it is definitely a legislative issue that some states, right? Every state in the U.S. has its own practice act, and those practice acts are very, very different from state to state, right down from direct access and how can a patient even access us as a clinician? Do they have to get a referral from their physician? Can you see them for X amount of visits before you have to refer to a physician? Or here in Arizona, we have full direct access. Unless there's some type of a red flag, I don't need a referral from a physician here in this state. So even down to how a patient comes to us is totally different state to state. And then under that practice act, what we can and cannot do. Can we manipulate? Can you only mobilize? Can you insert a needle? Can you not? Can you order an x-ray? Can you not? Right? Like, there's so many different things that go under the practice act. So yeah, at the end of the day, dry needling is state regulated. And so I always encourage people to read their state practice act to find out if needling is a skill that you're allowed to have, or allowed to have and allowed to practice in your state.
And have you got any courses or events on this kind of area coming up in the pipeline?
Yeah, we've got a bunch coming up. If you go to structureandfunction.net, you'll find a whole bunch of different foundational courses and advanced courses. We have a full 7-course curriculum with advanced classes focusing on more precarious areas like cervical thoracic and lumbopelvic hip. We host a dissection class because I felt really passionate that people feel comfortable and know their anatomy, which I know sounds silly because we think as physios or PTs that we automatically know our anatomy. But when you're starting to insert a needle into somebody's body, you really have to have an unbelievable understanding of what could possibly be on the other end of that needle tip. So we offer a dissection class where we use non-embalmed cadavers, so people really can get an idea of where the anatomy is, where that needle's going. So yeah, we have a full curriculum that you can find at structureandfunction.net.
And have you got any more books that you're writing currently, or have you got anything else that you're working towards?
Oh my goodness. It's so funny. I just got a request to write a book chapter, and I sent it's in one of my friend's books, which is going to be great. And I'm still so traumatized from the first book that this is my first writing project that I've taken on since the book, because I was super traumatized for like a year and a half. And so I swore I would never write another book. But so I'm going to start with a chapter in somebody else's book, and then we'll see. I guess I'm softening to the idea of a book, or at least an update to this book already. So what we're doing is we're putting this book online. So the book for me was always a jumping point to further education. So online education and in-person education, I wanted it to be a living, breathing thing that would begin the discussion versus end the discussion. And so as we're creating these courses and creating this online content, there's already things in the book as I'm going through it again right now, like, oh gosh, I would put this in a different chapter, and I would do this here, and I want to expand on this. So if anything, I kind of see maybe a version 2 or a new edition of this book sooner than later, rather than a whole brand new book, but you never know.
You're very modest about the first book, because it's a very good book.
Thank you so much. Oh gosh, I really appreciate you saying that. It was a lot of blood, sweat, and tears, that's for sure.
And where can people find you online if they want to get more information from you, other than the website? Are you on Twitter or Instagram?
Yep, Twitter, Instagram, LinkedIn. So just Sue Falsone. If you look up, I wasn't very creative with my Twitter handles, and then Structure and Function also has the same stuff as a company, so you can always kind of see what we're doing. We're doing some new and exciting things coming up soon here.
Brilliant. And I think we're on the clock there, but Sue, thank you for giving the sports medicine world the gift that is your book. I definitely think it's a must read, but also thank you for coming on the show. It's been great to talk shop and steal some of the pearls of wisdom from you.
Oh gosh, my pleasure. Thank you so much for having me on and for wanting to chat. And I'm sorry we're on a bit of a time crunch, but hopefully we can chat again, and people can reach out. And I just really appreciate you wanting to have me on.
Thank you. No, thank you. I'd like to thank Sue for coming on the show today. It was a great pleasure to listen to her philosophies on both performance and therapy, and I really can't recommend her book enough. As usual, everything mentioned on the show will be listed on the show notes at informperformance.com, and thank you very much for listening.